It is the students, past and present, that make our college what it is. So, as our twin institutes move towards a centenary, we want to give a virtual platform to every batch of GSMC to share their fondest memories of college. Their thoughts and emotions will be preserved forever in the form of these reminiscences. I would request Sir to display the GAA membership form. To remain connected to our alma mater and informed of the activities in KM, including its centenary celebration, we request you to become members of the Gosumec Alumni Association, the official alumni body at GSMC. All the details and this membership form are available on KM website. I would request Sir to play the Gosumec Foundation slides. The Gosumec Foundation was established in California, United States, to give back to our alma mater, which has helped so many professionally and personally. The website allows you to enjoy nostalgic content, including history of our institution, medical humanities, archives, and much more. So the first slide shows the web address, and at the footer of the website are links to social media accounts, including YouTube, from where you can access virtual reunions. The second slide shows the mission of Gosumec Foundation, which is connect, contribute with 3 T's and engage. Connect global Gosumecs with our alma mater. Contribute to alma mater's development by sharing the 3 T's: time, talent, and treasure. Engage Gosumecs with nostalgic media on a continued basis and enable global networking. This third slide highlights a secure alumni engagement portal exclusive to Gosumecs who completed the Google form, accessible through password reset from the email link sent or direct web page login from a homepage. This portal also comes with an iPhone and Android app. Explore features like alumni search by map, specialty, class groups, fostering connections and idea sharing, and much more. Okay. So now we bring you to the second part of Dr. Farooq Udwadia's interview. This will be followed by a recording of Dr. Temple Udwadia's interview. I will request Sir to now play the interview.
Varun, should we have the Gosumec scholarship PPT first? Yeah.
Yes, ma'am.
Yes.
I would request Sir to now present the Gosumec scholarship video as well.
USA scholarships passionately strive to empower deserving students by offering crucial need-based support, unlocking doors to success, and shattering the constraints of financial barriers. In its inaugural year of 2023, the Bridges to MBBS and More Scholarship with Jyoti Shanbag Haven Initiative proudly embraced and uplifted 17 scholars, comprising 16 dedicated medical students and one passionate occupational therapy student. Notably, the initiative celebrated the inclusion of 4 inspiring female scholars, marking an important step towards a brighter and more inclusive future. In the heart of Seth Gordon Das Sundardas Medical College, the growing demand for financial assistance resonates deeply, especially among our dedicated students pursuing paths as occupational therapists, physical therapists, and medical technicians. It's disheartening to acknowledge that occupational therapy students and medical technicians, despite their immense dedication, do not currently receive government aid, making them the most vulnerable in their need for support. Together, let's bridge this gap and stand strong with these aspiring professionals. The Gosumec Foundation USA passionately envisions a united Gosumec community supporting our noble cause, the Collaborative Scholarship Project. We dream of creating a nurturing space for students globally with backing not only from the US, but India and globally as well. Guided by Dean Dr. Sangeeta Rawat, this initiative will persist in championing students, fulfilling their financial needs, and offering invaluable mentorship through the Dosti initiative and the compassionate touch of the medical humanities team. Together, Let's weave a tapestry of support, transcending borders and fostering dreams. The Gosumec Foundation USA pledges to amplify the impact of every rupee raised in India, creating an exponential doubling of support that reaches even more students. Every rupee raised in India will be matched by the foundation. Contributions in US dollars from the US and around the world will find their way to the DGST account at KEM, while Indian donors can directly contribute in rupees, enjoying tax advantage donations to DGST. The joyous anticipation of students upon receiving this much needed scholarship is a testament to the transformative power of collective generosity. Let's come together, hand in hand, and passionately spread the message. Let's encourage and uplift one another to support this noble initiative, benefiting numerous aspiring professionals at our beloved alma mater, a place that has enriched us both professionally and personally. The unifying force of gratitude and generosity is poised to unleash an avalanche of much needed assistance, ensuring the enduring legacy of our cherished institution. Together, our collective efforts will make a profound impact and carry forward the spirit of giving back. The need based support provided by the Collaborative Scholarship Project is not just a financial aid, it's a catalyst for a virtuous cycle. In this cycle, today's recipients are poised to become tomorrow's donors, creating a profound amplification and sustainable continuity for this heartfelt initiative. It's more than assistance, it's the transformative power of reciprocity, ensuring that the spirit of giving thrives and grows through the hands of those who were once recipients. Exciting news for Indian Gosumecs. Join forces with Dean Dr. Sangeeta Rawat, Dr. Lopa Mehta, and HOD Physiology Dr. Shenvi. Your participation can create a meaningful impact as you contribute tax deductible funds to the Diamond Jubilee Society Trust, DJST. For every student supported with rupees 60,000 in fees, Gosumec Foundation USA will match that support, thus doubling the impact. Don't miss this incredible opportunity to collaborate, create positive change, and support a cause that truly matters. With gratitude, Gosumec Foundation USA.
Thank you for that, sir. Now we bring you to the second part of Dr. Farooq Udwadia's interview. This will be followed by the recording of Dr. Thempton Udwadia's interview.
Tushar, can we have part two of Dr. Farooq Udwadia's interview, please?
Yes, ma'am.
I know he was very good. What is so bad? I've done a great mistake. He said, what is it? Tell me, damn it, what is it? My first thing was that as soon as the patient was admitted, he should be scrubbed clean because they're all muck, literally dirt muck on them. They're poor people. Scrubbed clean thoroughly, absolutely, before you do anything. Instead of, I thought I was scrubbing with water, but I was scrubbing with carbolic acid. Oh God, I screamed at him. Yes, and shift him immediately. So we shifted him here, and I think it was the most difficult case we have had. He had burns, carbolic acid burns, he had a complete renal shutdown, he had severe tetanus, he had secondary infection, he fought and struggled, but he survived in the end. So this is, I think, a very pleasing thing. And the boys could see for themselves, and that is where I wrote my monograph. Besides the papers on tetanus, I wrote this monograph on tetanus, which was at that time a standard work on tetanus. And we did a lot of studies here. We studied the hemodynamics of severe tetanus, which had not been done at all, ever. All the cardiac output, the peripheral vascular resistance, pulmonary artery pressure, pulmonary vascular resistance, everything. And why and how we manage these patients with severe tetanus, grade 4 tetanus, with severe autonomic disturbances. And why they used to die earlier on. And what is it that we did which helped them to survive? So that's probably the best work I've done, if you ask me. Besides the critical care, that I established in this hospital first. So that's how it was, basically. I think I answered all the questions. Yeah, it's nice to ask this question. The most important thing in medicine is to practice medicine the same way with everyone. If you make distinctions, you could never practice it. Let me just give you an example. You have a person who's well known. You feel, I think we should go ahead and get a tracheostomy done. But there will be pressure put upon you. Why are you doing it now? Can't you wait? If something goes wrong, there will be lots of noise. Go ahead with it. If you want me to look after you need to do tracheostomy. I can explain everything to the relatives. But this is why we need to do a tracheostomy. That is it. But if you say that no, it's so important if something goes wrong. But the pressures can be very great sometimes, and it's not easy to withstand that. It's certainly not easy to withstand that. But if you follow this cardinal principle, that you will treat them exactly. Forget who he is, forget who he is. What would you do if you were Mr. So-and-so who didn't know who had it? What would you do? You would do a tracheostomy? Yes, I will do it. Then why should I not do it? If you do that, I think you can handle it. And you need to be a little lucky also. Medicine is something like this, if something can be. But then, you're doing it because you feel that's the right thing to do. You're doing it out of good judgment, your personal judgment. Some judgments can be wrong, of course. You are expressing sometimes. But I think that's the best way to go about it. But the pressure is great. The pressure was very great when Amitabh Bachchan was here. I used to keep this window open because there was a mob outside. And I knew that if you were to die, they would probably burn the hospital and they would burn me with it. So I said, I'll escape into the Arabian Sea from here and come out somewhere in Marina service and die. Something like that. That was. But he was a gentleman. He's one of those actors who was really a gentleman. So that's the most important. The emotional pressures are great. Emotional pressures even now are great. Keeps you awake, particularly when. That's why I think I've come to a stage when I feel that now I should stop looking after ill people upstairs and just be content with just sitting my work here. And perhaps look at references that I can do and not take immediate responsibility of patients who are very ill. it's high time. My wife has been saying that for ages, but somehow or the other I'm not yet. TV, I'm very, I live in this cocoon. I'm completely divorced from the outside. And you won't believe it, I've forgotten one day. One of the things I will do when I stop working is to rediscover all the roads and the streets. Because my journey is from home to here to home. On a Sunday, home to the club, have a sandwich and a cup of coffee. And that's it. And to the NCP, which I'm very fond of. So I'm really totally, even the medical people, I'm completely outside their ambit. So there's no way of doing. I refuse any press interviews, by and large. Very occasionally, if it's a book which has come out and somebody wants to talk about it, that's fine. But otherwise I refuse all TV. Once at TV, yes I did, when people from Brompton had come down and they had organized a conference and they had inflicted on me the duty of being a president of that conference. I've never stood for any official post in anything at all. I don't think I personally don't like to do that. But apparently I believe there must have been a squabble between other people and they said let's put this idiot into the thing so that they don't fight now. So that's how I think I became a person. Otherwise I've never been in any. I've taken part in most of them. I've spoken at many conferences, almost all over the world. But I've never been a secretary or president or this or that. Humanities have always been very important. I used to read when I was in school. In fact, I did most of my reading before I joined medical college, basically. And a good bit of my reading after, I came back and had no work to do. So that was the time, when I used to read a lot. And even after that, I very often used to read at night, late into the night. It's something which interests me, particularly history. So I used to read a lot, and I have been reading a lot, and I still do whenever I get a chance. Yes, this is important. Bedside medicine is a dying art. When I came back, I used to see KM, and I used to drop in at the KM, nothing to do in those days, before I got drop into JJ. And teaching was in a separate room where they would, have a patient and they would, give the causes of hemoptysis and how to treat hemoptysis. But the real bedside teaching, which we used to do, was no longer practiced. My main drama at JJ was on Wednesday. And you won't believe it, but people from KEM, JJ, Sahib, all used to come and we had 40 or 50 people with me. I used to work literally. And it was always at the bedside. Always first the history. What have you made out from the history? Have you come to any diagnosis on the history? What lines would you make there? How are you feeling the spleen? It's not the way to feel the spleen. Look, this is the way to feel the spleen. Listen here, what do you hear? That's what the teaching is no longer there. So people have forgotten to use their eyes and ears and hands. And they just look at ECGs, or they look at a scan, or look at some figures churned out by a machine. And I see here also people sometimes from outside, newer people who come. They don't even look at the patient. They don't even talk to the patient. They talk to the registrar. Ask him this question, this question. The registrar is carrying on. Your patient is. Can you imagine yourself being in that situation and feeling that this guy who is supposed to be looking after me has even not even talked to me? That's the what medicine is talked to, and that's the sad part. I think it's so sad to watch it. And it's not only here, because I have people sometimes come during the term and they meet from Guy's Hospital or sometimes from America or sometimes from Australia, not very frequently, but at least in the year, a couple of times in the year, they spend a couple of months with me. The same. And when I asked this guy who was his family MBBS, he said, this is not the way to feel the spleen. He says, yes, I do. So the thing is, why is that? He says, there's so much to study and we have such little time with patients. That's the reason. We didn't have genetics and this and that. The sort of biochemistry that is taught. There's so much to study there that they say that, and look at the way examination works. So in our days, there was always a clinical examination where you have face-to-face with the patient, you just talk until you discuss the patient. Nowadays, they have a case scenario. Man age 62 comes with this, with this, what will you do? Right, you've done that. Now what will you do?
No patient.
No. It's all imaginary. Completely different to a patient. The man with this, he has glands here, he has a spleen, he has that. But how do you know that? The examiner would have found it, the student would have found the spleen and would have found the glands to start off with. Isn't it? So there's that big vacuum. The reason being is that there are so many medical students. So how do you look at so many students or examine so many students? So that give these papers to them. That's how it is. That's that thing. So, time for reading and writing, as I said, I'm a bit antisocial in a way. I don't attend these parties as far as possible. And when I want to do something, I disappear for some time, leaving my locum, and I'm dead to the world. I do what I have to do for a long time. Performance of tests also now, even I have got into that. Doing tests which really are not necessary. But sometimes I feel, if something turns out and you miss this because you didn't do this test. But even here, doing the test from A to Z, a man has had a headache for 20 years. He's had migraine for 20 years. And 8 days and he comes to you saying that my headaches have increased for you don't have necessary to go and do a scan for an X-ray, isn't it? But that is, what happens. Or a man has a chest pain, he goes to a cardiologist, you don't necessarily find go to do an angio, and have you found out that his son has become somewhere or the other, and that this is an emotional stress that he has. Where is the history? No history. It's just this chest pain, get this. Pain in the lower part of my tummy, colonoscopy. That's what medicine has come to. Right? It's a sad thing. Dealing with the human beings is so important. I think the basis of clinical medicine is the bond between the doctor and the patient. I mean, I'm not talking of people who come to this simple cough or a cold or anything else. He gets well on his own. You don't have to spend a lot of time. But if a person is really ill, it is very necessary that you build a bond between the doctor and the patient. The patient has to trust you. The patient has to have faith in you. And that's so important. People are really very ill. Faith is a very important thing. Faith is so very important. I don't know how it works, but it does work. Somehow, someway or the other, it's only the mind-body complex which is responsible. Patient has faith in you, it's a good bit of the battle on your side, and he's really ill. And it's amazing how a patient can make out a person who's shamming and who doesn't really care from a person, doctor who really genuinely cares. So I think a doctor-patient relationship, the bond between the doctor-patient relationship lies at the very heart of clinical medicine. Medical approach is so important. Even now, for any really ill patient there, register, of course, a lot of boys also write their daily notes. I write a summary on that patient every 6 or 7 days, which sometimes can go into pages. I write everything that has happened, everything that has been done. Also, I write why I have been thinking on these lines and what is my differential on this point. Why I have done this and why I have not done these things. Why? Because in these days, if you have something on record like that, it immediately shows that here's this person, who's scared. Of course I can make a mistake. Of course I've made mistakes. But at least I've done my best. And that's all that you can do. And that's important. If you have done your best and you haven't recorded what has happened, it's
Nobody
important. It's in these days particularly. I think it's very important. You inscribed one poem, I think, not a poem, but I will never forget the lines of Rabindranath Tagore, when as a poor student in London, no money in my pockets, eating Cadbury's chocolates for the last 7 days of the month. Because in those days, you were allowed only a certain amount of money. And it was very, very difficult to live on that money. So I first started at the Indian Students' Union Hostel in London. It's an Indian Students' Union Hostel, which is cheap. Even then it was difficult to get to Wednesday. And there on the wall was a beautiful line of Rabindranath Tagore. Shall I try and recollect it for you?
Yeah, sure.
Do not forget, my friends, to stand before the proud and the mighty in your white robes of simpleness. Let your crown and let your freedom be the freedom of the soul. Then build God's throne daily on the ample bareness of your poverty, and know that what is huge is not great, and that pride is not everlasting. Yet your crown be of simplicity. I forget the first line, the second line. Let your crown be of simplicity, your freedom the freedom of the soul. Build God's throne daily on the ample bareness of your poverty, and know that what is huge is not great, and that pride is not everlasting. That's very nice.
No, I haven't read this. I didn't know this.
Yes. Let your crown is simplicity. Yes, simplicity and your freedom, the freedom of the soul. Build God's throne, the ample bareness of your poverty, and know that what is huge is not great, and that pride is not everlasting. I think those are words for a student. Isn't it?
I agree. When you look back on your long career in medicine, what satisfies you the most, and what is it that gives you the biggest regret? Not having been able to do something.
Yes,
or
what satisfies me the most is to have somebody who's very, very ill, and who everybody says, okay, well, let him go now, he's not going to survive. And you say, no, I can't let him go, he's so young, he's not got a cancer, he's got a disease which potentially is reversible, so let's not give up, let's carry on. And he comes back and he leaves. We have a patient like this just now, a young man who had H1N1 and was very, very ill, had gram-negative sepsis following that, severe years, and held on for some time, and then seemed as if he was going to die. And then the next day again became held on again, and is now on the way up, and perhaps he was spending it more. And it's quite interesting, the young wife. One day I told him, I'm so sorry, I don't think we can do much more than we've done, and I don't think we're going to see it through. And she was sad. So I said, what can I do? I said, yes, you can. I said, go and pray. So the next day, things suddenly seemed to turn around. And I tell her, you know what, he's a little better today. I'm sure it's because I prayed. I said, yes, you're right. It's because you prayed. Go again and pray. This is helpful. You know, these things, are satisfy you so much. And the regret, of course, is, if you failed. If you tried your best and, it has come to a zero. Originally, the regret was also sometimes the ingratitude of people whom you looked after. But then, in one of our prayers, and I always tell this to the boys, always I tell them that righteousness for the sake of righteousness. What you are doing is what you think you are doing. You are doing what you are doing because it's just the right thing to do. That means you are righteous for the sake of being righteous and for nothing else. So don't expect anything out of that. You have done a real duty by doing the righteousness for the sake of right, because it is the right, because you think this is the right thing, therefore I am doing the right thing. Nothing else should matter. You must look at life in that. Because there are any number of people who are very grateful and shower you with gratitude and all that. And there are a few, not many, but a few, quite ungrateful. So what do you do about that? Nothing. You look at it philosophically, you say, I'm not doing it to get gratitude. I'm doing it because it's the right thing to do. So it's very difficult. You can't easily set that down. But I think it's at least a philosophy that one needs to accept. So that's what makes you sad sometimes. And there's a lot of sadness in my work. You see. So I'm no longer the very mischievous and the very sort of outgoing chap that I was when I was very young. All this, naturally preys upon you all the time. And even if you don't want to, you change. Automatically you start changing. You go to a blooming dinner and you think of big number 3, I don't know what's happening to me. I'm not able to understand why this is happening or what am I supposed to do. And there are people who are chatting and talking about rubbish, and what am I doing here? What am I doing here? I'm living at home, that sort of thing. That's the sort of thing also that happens. But that's not nice also. The great is the fellow, dissociate himself, do the same work and yet dissociate himself and not be sort of burdened by it to a great extent. That's the whole truth.
One last question. What is your philosophy on religion?
I'm a religious person. I really am a religious person. I do feel that there is some outside force which conducts this universe. It's not a man, obviously, it's not a woman, obviously. I think it's a force of some sort or the other from which this world emanates and which controls our destinies in some way or the other. My religion doesn't believe in karma, but I do believe in karma. I can't see any other explanation for this world. How can you expect children to suffer, innocent children to suffer and die and suffer also without having some explanation for that? I mean, nobody is going to prove it. But isn't it true that some people have been able to say what their past lives were? Isn't that so? I have read of people saying that they know what their past life were and they've been able to go to that life and prove that this is where I was, this. I don't know how true it is, but it's possible, I think. But I'm very religious and I pray every single day. Before I go to work, I pray. I sometimes pray too fast. You can't. My wife says, how can you pray so much in 15 minutes? It's impossible. What are you doing? So, but at least I pray. I don't ask anything always when you pray. You just thank God. That's it. If you ask God, give me this, give me that, give me a Mercedes, give me this, it's pointless. If you just thank God. And I pray sometimes for my patients. I always pray for my patients, every day.
And if you had to talk to a person or to the person's family who is dying, what counsel would you give them?
Oh, I sit down and talk. I sit down and I spend quite some time with them. And there is a side room to our. Normally, I talk to the patients' relatives outside. When I got to the door, to each group of them, I tell them what is happening and lay answer all the questions and tell them the truth, the exact truth, what is happening. But when a person is really very bad and there is a chance that he's going to die, there is a side room where I sit them down and I tell them everything that is to be told and answer all their questions because they have always questions to ask. And tell them to be philosophic about it, that that is life, that I can't do more than what I have done. I always give them the option, you want anyone else to look at them, you tell me and I will get that person to look at them. Any other doctor to look at them, for example, or anything else you want that. Sometimes they ask the impossible and they say that's not worth it, that's not possible. It's not worth doing. Can I take him to America? He can't survive the journey to America.
But is there any philosophical kind of...
Yes, the philosophy is that, death is just part of life. I mean, everyone has to go. Everyone has the time to, there is a time for everyone to go. And that is not just in our hands. You have to accept what is happening. It's a question of acceptance. It's tragic, it's sad, but you have to accept it and you have to move out. You have to. There's no other way. You just be as philosophical as you can. Not give them a lecture on philosophy. Just give them solace, more than anything.
You said that you were mischievous as a child. Are you still mischievous?
No, I'm not mischievous now. I'm not mischievous now. There's no time to be mischief actually, if you ask me. I was mischievous right up to college, right into college, right till I passed out. I finished my MD. In my quarters, I was a very mischievous. I used to play the violin. Unfortunately, for the last 6 months, I can't. But I used to play the violin. And I remember in my quarters playing the violin on the roof. Sloping like that, standing on the roof between the male hostel and the female hostel.
So literally fiddler on the roof.
Fiddler on the roof. Literally a fiddler on the roof. So all sorts of things. All sorts of things. Can you jump from the second floor? So I said, let me first try from the first floor. That was in school. So jump from the first floor. But then when I went up to the second floor, I said, no, I didn't get good jump from here. But there was a boy who did. You won't believe it. There was a boy who said, I'll jump from this floor. And he did. And went up. Perfectly all right. Got up and went up. So those were the days we knew. But at home, of course, there was no real mischief. And when there was mischief, it had to be good mischief, otherwise you had it.
I think we've taken up a lot of your time.
Thank you.
Thank you.
Thank you very much. Thank you. Let me back into old memories.
You've been very, very patient.
Thank you. Thank you. Thank you. Thank you.
So that was the interview we had of Dr. Farooq Udwadia. We'll now be playing an interview of Dr. Temple Udwadia, which was conducted by Dr. Ravi Ramakantan, sir. Before we actually play the interview, I'd like to read out a small introduction of Dr. Udwadia, which has been penned by Ravi, sir. Born 15th July 1934 in Mumbai, Dr. Udwadia did his early education at St. Mary's School and Wilson College. graduated in medicine from St. G.S. Medical College and KEM Hospital, and started his career as a research fellow at the King Edward Memorial Hospital and St. Govardhan Das Sundar Das Medical College in 1958, wherein he stayed till 1962. During this period, he studied for the postgraduate MS degree that he obtained in 1960. Moving to the Grant Medical College and Sir J.J. Group of Hospitals in 1963, he worked there till 1994, till his superannuation, and then continued his association with the Institute as an emeritus professor. In between, he also worked as the Hunterian Professor of the Royal College of Surgeons of England during 1984-85 and Sir James Ross Lecturer at the Royal College of Surgeons of Edinburgh in 1992. Dr. Udwadia was the founder president of the Indian Association of the Gastrointestinal Endosurgeons and presided over the association from 1993 to 1998. He has served as the president of the Society of Gastrointestinal Endoscopy of India, Association of Surgeons of India, and the Society of Endoscopic and Laparoscopic Surgeons of Asia. He has been the president of the Indian chapter and the world body of the International College of Surgeons. Dr. Udwadia has published over 90 articles in peer-reviewed journals and is the author of 2 books, Laparoscopic Cholecystectomy and Laparoscopic Surgery in Developing Countries. His latest work, More Than Just Surgery, is a lot more than an autobiography. It is a pathfinder for aspiring doctors. Dr. Udwadia received the Sages Millennium Award from the Society of American Gastrointestinal Endoscopic Surgeons in 2000. The same year, he also received the prestigious Dr. B.C. Roy Award, the highest Indian award in the medical category from the Medical Council of India. The Indian Association of Gastrointestinal Endosurgeons awarded him the Lifetime Achievement Award in 2004. In 2006, he was also awarded the Padma Shri. Dr. Udwadia passed away in January 2023 due to complications from advanced cancer. We will now be playing a recorded interview of Dr. Tempton Udwadia and listen to his experiences and his memories. I request Tushar to please play the interview.
I'm here. Okay.
Good evening, sir. Welcome to your alma mater one more time. All these members are being made as a part of our centenary celebrations, where we want to have wisdom from all our alumni, especially illustrious ones like you. My name is Ravi Ramakanthan. I'm a radiologist from GS Medical College. I joined the college in 1971 as an undergraduate student and retired in 2010 as professor of radiology. 40 years, every stone, every dog knows me and I know them. So it's a great privilege, sir, to talk to you about this whole thing about medical education and medical practice and tap upon your wisdom of what this is all about as far as you are concerned. Dr. Tempton Udwadia needs no introduction. And so, sir, I'm not going to introduce you. Tell people that if you want to know about you, to read your book, More Than Just Surgery, Life Beyond the Operation Theatre. I have not yet read the book, and I'll tell you why at the end of this interview. A surgeon who writes such a large book, which has been highly reviewed, must be a unique individual. Your career talks about that openly in terms of what you have done for your patients and for others in the true spirit of non-Sibicel omnibus. I will want to say that this is not the usual interview in which we go to every aspect of your life. I would skip large parts of it and let people watch that on YouTube. There are many more interviews that go through that. There's a book that I told you about that talks about your life. But this will be a sort of very partial interview to questions that I, as a medical teacher and a practitioner who is still in contact with medical students and fellow practitioners, have on issues that need a lot of wisdom to solve. But before that, I would start with your school education, sir. St. Mary's School. I would just bypass that. St. Mary's School is full of naughty boys who are more often on the playground than in the classroom. I'm just kidding. But I envy the playgrounds of that school on the Nesby Road. I've been to the school a couple of times and such luxury being able to play. What was your favorite sport in school days and later?
In school days, my favorite sport was cricket.
Oh, okay. And then?
Then, when I started my surgical practice, I was very close to Bombay Gym, so I used to play squash after my consulting rooms. And squash played hell into my knee, so I turned to golf. And for the last 55 years, I've been playing golf.
Okay, so you have been there with multiple sports. And what do you think is the importance of having a real sport in your life and a hobby as you become from a medical student to a practitioner? What role do they play in the life of a doctor?
I think sport plays a role in everybody's life, not just a doctor's life. Sport teaches you the importance of team spirit, that you are just one of many and you pull along like a tug of war, you do the best you can. But sport also teaches you like golf, for example, it teaches you to keep your feet on the ground, that you are open to error all the time, and the importance of converting an error and bringing it back on track. That is part of sport. It keeps you on a level playing field all through.
What about a hobby? Do you have a hobby?
Reading, writing.
Okay, I can see that for someone, a surgeon as busy as you were, to write such a big book, it must be a obsessive compulsive behavior. It's quite simply amazing that you were able to chronicle your autobiography in that book. I would now switch to those days where you had to decide to enter medical school and you chose GS Medical College. Why did you choose GS?
My father was in the other JJ school. That time, that was the only school actually.
Yeah, okay.
And then my brother was already in the GS Medical, and he said that this is according to a better medical college, and so I followed him into GS Medical.
Okay. Sometimes it happens that the dean addresses brand new medical students, and sometimes it happens that the professor of, say, anatomy or physiology would ask all, in my time, 160 students, when you finish MBBS, what do you want to do? Had you been asked that question on day one of your medical college, what would your answer have been?
Surgery or general practice. You see, my father was a general practitioner, and I would often go to his dispensary many times as an undergraduate, because after cricket practice at the parallel grounds, it was just a short walk to his dispensary. And very often I'd go there and see there. And I thought that I would be either a surgeon or a general practitioner.
Yeah, I mean,
the other choice would have been a pilot.
Sorry, what?
If I didn't get into medical college.
Oh, okay, okay. Beyond medicine.
I'm a pilot.
So you are sharp shooting all the time. You spent several years in GS Medical College, undergraduate, postgraduate, all that. Who were your favorite teachers and why?
On the medical side, Nathubai Patel.
Okay.
Because he was out of the box, not routine 1, 2, 3, 4 causes. He was more surgical than medical, I think.
Okay.
And among the surgical side, there was Arthur Disa, who was my postgraduate teacher. My MS thesis was with him, and Professor P.K. Sen.
Okay. You talked about MS, and that brings up this topic. What was your dissertation on?
My dissertation was on acute intussusception in infancy and childhood.
Okay, and
The Udwadia Children's as a resident.
okay. When I became a medical student, we just had one lecture by Dr. P.K. Sen, and everybody knew of his heart transplant fame. Why was he one of your special teachers?
He was a phenomenal thinker, and on his desk there was a plaque: "Those who reach for the stars reach too low." And that was his approach to surgery.
Okay.
Okay. And this is a sentiment he would pass on to all his registrars. And if you see the sequence of his registrars, all are done brilliantly. I was the first of his thoracic surgery registrars, and Bhattacharya was the last of his thoracic surgery registrars.
Mm.
And in between, there's a whole string of people. I was general surgery and thoracic surgery.
That's a lot of luck there. Very good. We talk about teachers in medicine, and we talk about role models in medicine. What do you think is the place of role models as teachers in medicine?
It is everything. A role model literally shapes the pliable, plastic young person's personality, thought processes, his ethical approach. He really makes him. For that matter, also a role model in my time was Dr. R.N. Cooper, Rustom Cooper. He was emeritus. He had retired long before I entered the college, but he used to come regularly for our postgraduate classes. And he'd come half an hour early because he knew we were stressed for time 6 months before the MS with ward work and study. And he'd make his drawings, jot out his points so he didn't waste our time. It was all on the blackboard. And that in itself was an indication of his approach to students and teaching. And he was a real role model. The last sentence he said to my batch of students was that I am proud that my residents are doing bigger and better surgery than I ever did. I think that is the mark of a great teacher.
Yeah, there is this saying in one of the radiology books, forward by a great radiologist: the greatest joy in the life of a teacher is to be completely outshone by a form of pupil. So it's phenomenal. We come back now to a little bit of present. I do not know how much in touch you are with the modern, I won't say modern, the present day medical education, medical admission, so on and so forth. Briefly, it is a battlefield out there. All children who are 17, 18 will appear for what is called the NEET exam, NEET national exam. And I call this a battlefield, and the lucky ones will get into medical school, so on and so forth. They are 17 or 18, and they come from cutthroat competition, and they come into medical school. So all that they know is how to put down the other guy so that you can get on top. It was not so bad in our time, and I suppose it was much better in your time. Therefore, I've been thinking of this, that if you have children who come out of such a medium, and maybe from 8th standard, they're going to tuition classes. If you have such students, 17 or 18, and put them into medical school, before that, should we not be having 1 year of compulsory liberal arts education to these kids as a part of the medical curriculum? What do you think of such an idea?
Absolutely. I think they come in raw, immature, and with only one aim in life: to be on top. And I think that is a sad way of starting your education. If you come into medical college with the idea of having read something, even if it is not Shakespeare, if you read something worthwhile, you read about famous medical people, you read what they did and how they did it, I think it will attune them to a better approach. And suppose you read the life of Schweitzer, for example, they would come with not I must be top of the rank, but I must do good work. And that, I think, is what they should enter as their aim when they enter medical college.
Yeah, I mean, I have been having some thought on this, and I think it's eminently possible to do it practically, but it may extend the medical school days by 6 months and 1 year. And what is 1 year
What
in a
is 1
lifetime?
year if it gives you a broader education?
Exactly. I mean, it makes.
No, I think in India they become doctors too immature.
Yeah,
You know,
that's true. Yeah, and that's not the end of the story. And then internship, instead of working with patients, they are studying for their postgraduate entrance tests. I mean, it's a
and
very messy
you see,
situation.
we are so exam oriented that we are not knowledge oriented. We are not patient oriented. We are just wanting to get the exam over with. And then at the end of it, we find that we have some superficial examination knowledge, but no real culture of medicine or surgery.
Sometime back, I'll tell you a shocking incident. I was talking to a senior surgical teacher in GS, and I said, "What is this? Today's students, they come to postgraduate in radiology. They don't know how to put on gloves. They don't know where to stand in front of a patient. They don't know to palpate the spleen. They know nothing about clinical examination." And he told me, "Ravi, why do all this? When we want something, we will do an ultrasound or a CT scan." That's a senior professor in GS Medical College. When there are many others who say things similar, what do you want to say about that? This will be an open letter to all such teachers.
I think this is shameful, and that this happening in GS Medical College is to me shockingly shameful. I think that the art of touching a patient, the art of talking to a patient, the art of being empathetic with a patient is more important than any investigation. Because medicine is a human art. It is a one-to-one doctor-patient relationship. And if that relationship is through a CT scan or an ultrasound or an MRI, then I think the future of medicine and surgery will be robotic.
Yeah, I mean, one part of the problem there is even my generation, which is maybe 2 generations removed from the current batch, had rigorous clinical education in the ward. We would do all sorts of things that you people did, ward rounds, you have your patient, night emergencies, etc. I believe that's not happening now. I understand
And the
it's not happening now.
notes, daily notes for the patient,
Yeah,
the undergraduates, operation notes, post-operative notes. I think this was part of our training process. And the chief would read the student's note as frequently as he would read the registrar's notes.
yeah, there would be a column there on the main indoor paper, clinical clerk, and we had to sign that.
Yes, sir.
Yeah, so I should go to KM one day and see if that column is still there or not. So I ask medical students often, why don't you go to clinics? And they say, we go to the clinics, the teachers don't come. When I ask teachers, they say students don't come. Part of the problem, which is, I mean, all of this is personal experience. I talked to deans, a couple of deans in the last few years. I talked to faculty in KEM, and all of them say, "Sir, what to do? Our colleagues are not in the hospital. They are busy in private practice." I mean, we were part of the team, not the team, the whole gang that was there when private practice was introduced. It was done with great intention that faculty would be available in the hospital during working hours, if there is anything like working hours for doctors. If that is being violated left, right, and center, what would you want to tell? Again, this is your admonition, your request to all faculty at KEM and GS who do not do their
I
duties
would
as a medical
say
teacher?
is that I'm the product of the honorary system. It has been greatly maligned, but I can tell you that the honoraries would come, they would spend their time with the students, with rounds, all of them, Dr. Kamarkar, whose husband I was, Dr. Sen, of course, was full-time, Arthur Desau, Pandya, everyone would be, Vasant Sheth, he would be there till 5 o'clock in the evening. And they would bring their own instruments, they would be there for emergencies, and their quality of work and the dedication to do free work, totally free work, was inspiring to residents. We were inspired by them. And I had the good fortune for 32 years to be an honorary at the JJ Hospital because I did not want to become full-time. Professor Sen gave me a letter saying you are appointed as assistant professor. And I said, sir, on a salary of 750 rupees, I will be disgruntled, unhappy, or I will do moonshining. And I don't want to be either. So I'd rather go into JJ as an honorary. And he helped me get into JJ as an honorary.
So we are coming back to that issue of medical education by the bedside. And if that is not happening, what would you want to appeal to the current generation of faculty who is in GSRK? After all, you are here as an illustrious alumnus of our alma mater. What would you want to tell them that they are not still teaching as it should be? You talked about honorary full-time. I think it's who you are. It doesn't matter whether you are an honorary.
Exactly. It doesn't matter.
Yeah.
I think if I was a full-time, I have been seeing how Sen was a full-time. And I think it is obligatory that you, on clinic days, you will take a 3-hour round, see every patient, and either check with the senior residents or with the undergraduates on essential clinical examination. And not only clinical examination, but to present the case, the history, how the boy has or girl has talked to the patient, what information has they received. And I think clinical medicine and surgery, if it's lost, I think that institution is doomed. You have to have your foundation, and your foundation has to be a doctor-patient relationship in terms of empathy, in terms of talking, in terms of examining. You look if there's any clubbing of the fingernails. Everything is so important in clinical examination. If you can't palpate a liver or a spleen, you can't get the rebound in an acute appendix, I think you are not fit to get the degree behind your name. You will get it, of course, and you will get distinction perhaps. But in my opinion, you are deficient.
So I asked this to many faculty who said this. Listen to the patient, he is telling you the diagnosis. Maybe 1 in 10 will be able to tell me that it was William Osler. So, I mean, that aspect of history taking and medical exam, as I told you, I gave you a concrete example, is unfortunately going away, but I still think everything is not lost. Maybe one day we would get you to the main lecture theater and talk to all of us about what you
I would
really
love
think.
to do that. I would love to do that.
Yeah, we will do that as a part of our centenary celebrations. And Lopa Mehta, who is professor of anatomy, or Dr. Sunil Pandya, and we will arrange for it at your convenience. You have to talk to the students here are bright, very bright students. And I tell them, you are very intelligent people with no brains, and they get mad at me. I mean, how can you say that?
Brains, they don't, it's not channeled.
Yeah.
It has to be there.
I then want to latch on to what you said, that you went from GS Medical College to the JJ Hospital. And I don't know if you are aware, across the Baikula Bridge, there is warfare between JJ and GS, a friend suffered.
I've suffered in that warfare. I've suffered in my postgraduate exam, that warfare, because friends registrar, and I was particularly targeted.
Okay, what do you think are the major differences? I mean, I don't think, again, JJ and GS makes a big difference. Again, it's the people who there are important. So what did you find any difference, if at all?
I'll tell you, in KM, there was a sort of a learning, learning thrust. It was in our A to learn, to attend clinics. I mean, in my medical term, I used to attend Dr. Baliga's clinics because I wanted to be a surgeon. And we had a certain intensity of wanting to learn. In the end, I don't know about other special, but in research, in surgery, at that time, KM was absolutely, I mean, we had 3 dog labs running constantly, 3 dog tables running in the experimental surgery lab, running constantly. And I was in the experimental, even when I was at JJ, I was working at the dog lab with Professor Sen. So there was I was asked that I can't be in 2 teaching hospitals at the same time. So Professor Sen very smartly said, okay, you become a student, do your PhD here, and you continue as a professor at JJ. So I was in the dog lab. That was the main difference. When I went to JJ, the word research was anathema. They would laugh at you, you know. But on the other hand, there was, amongst the students of JJ, liberalism, which was wonderful, you know. So both hospitals had their very major plus points. The students at JJ, a large number of them at that time, were from out of the country, from Singapore. You see, we would give them seats for international students. And there was a very nice, happy swing in the JJ students. The clinics were fun at the JJ. And I mean, at the end of the clinic, they said, sir, you exhausted us, please take us to the canteen. That was the manner of JJ teaching at JJ.
Yeah.
And I was very fortunate to be in a unit where I was given such a free hand. You know, I could do things like thoracic duct jugular vein anastomosis and other things for jugular vein to CSF anastomosis in hydrocephalus. And I could do all this because I was in a very liberal unit with Dr. R.A. Irani and Dr. Sikh Patel. They were liberal chiefs. And I do laparoscopy because they were so liberal.
Yeah, I mean,
they didn't have the attitude that because I'm not doing it, you can't do it. And I was very grateful for that approach that I had in my unit at the JJ. So it was not in every unit at the JJ, I must say.
You mentioned
I'm
about...
very happy 32 years at the JJ.
Oh, okay.
Happy as I had at the KA.
Yeah, I mean, we have had some undergraduate students from JJ come to KM for post-graduation in radiology, and we hear these stories from them, and they say that there's so much fun in JJ working with great teachers. They are still there. But you mentioned about the thoracic duct and the jugular vein. I want to take you back to 1971. I still remember dissecting that area and seeing the thoracic duct go into the left subclavian vein, which brings me to this issue of your view about the need to dissect human bodies rather than do it on computer. What do you think of the role of dissection in whole of medical education or practice rather than just anatomy?
I think this is your basics. You can't learn dissection on a computer really, because the feel is what makes the difference. And minute dissection, for example, like a jugular vein or a thoracic duct, it is a craft. It is not something that you do mechanically or do on a computer. It's training your hands to a very specific craft. The anastomosis of the thoracic duct, for example, which is so friable to the jugular vein, requires a lot of, I use magnification, but even so, it needs a fair amount of craft. And I was doing it for intractable ascites at that time,
Okay.
1970s, because it was felt that the multiple openings of the jugular vein had a back pressure. So a wide thoracic duct implanted into the jugular vein would have much better drainage.
Okay.
This petered out like many things, but we did this for about 2 years, and a lot of patients were referred with intractable. At that time, 70s, ascites was intractable for many reasons.
Okay.
And we had a lot of cases. So these are the things that JJ gave me. And I think I could do it because my background with Professor Sen in experimental surgery.
We talk of Dr. Sen so often, and I think he was hugely larger than life. The whole lab of vascular radiology is because of his benevolence. He got us a Rockefeller grant of $25,000 US in 1965, and we first
I was
had.
at the KM in 1965.
Sorry?
I was at the KM in 1965.
Yeah, so you must have seen that old 53, where we had, at that time, the state-of-the-art biplane angiography machine.
Yes.
So the huge thrust of cardiac radiology or vascular radiology was courtesy Dr. Sen. Of course, you mentioned the dog lab, and that must have been unique in the whole of the country to have a dog lab in a hospital and medical college. And what a luxury!
Dog lab had 3 dogs running simultaneously.
Yeah, I've seen that seen those tables, and it's quite unbelievable what that man
did at that time was godsend.
Yeah. Now, I wanted to ask you about laparoscopic surgery and Dr. Udwadia, and you gave me an opening to that, saying that you had that freedom and therefore you could start laparoscopic surgery. Tell us something about that, because you are so huge a person.
No, you see, everything is providential. It's not that I had the brains or the special ability. What happened was that we had 50 patients for a capacity of 20 in our ward. And that was because there was no backup facilities. A barium meal would take 3 weeks, 4 weeks to material. And Rasik Patel, my senior consultant, and I used to wonder how we can improve the turnover. And one day I saw Dr. Nagesh Motash, while I was waiting for this, I saw Dr. Nagesh Motash do a laparoscopy. I just peeped into the next theater and she was there. And I said, Nagesh, what are you doing? And she said, I'm doing a laparoscopy. I'd never heard that word before in my life. So I said, what is laparoscopy? So she said, scrub and have a look. And when I had a look, I realized that this was the answer to diagnosis of our patients in JJ Hospital. And that is how I entered the field. Purely by accident, by my accident of my anesthetists being late and Nagesh being in the next theater. So not my intellect that brought me into laparoscopy, but pure accident. But then I realized that this was what was needed. So I went to Germany, got a set, because the import duty at that time was 320%. So it was to fly to Germany and bring the instruments. And we started diagnostic laparoscopy in 1972 at the JJ.
Okay.
And we were doing very well. Of course, the city surgeons thought that it was a total waste of time and bullshitting. But the rural surgeons were very happy because the laparoscope was available to them for family planning all over the country. So rural surgeons picked up diagnostic laparoscopy and benefited from it. And when operative surgery came, we obviously had a head start because we'd been doing diagnostic laparoscopy. Over 3,000-4,000 cases we had done by that time. So we entered the field of laparoscopic cholecystectomy.
Okay. we have spent about 20-25 minutes on this. I want to change gears and ask you some, I mean, it's crude to call it that, practical questions
Right.
about how you handle real life situations. Suppose you get a phone call from a brand new MBBS student comes to you and says, "Sir, I have come from interior of Maharashtra. I have no one in Bombay to look after me. I know nobody in the college. I have trouble speaking English. Sir, will you be my mentor?" What would you say?
I would say that I would happily be your mentor, but you need to have a position in the hospital. I mean, you see, you can't just follow me, because without a position, he won't be allowed to examine patients, touch patients. So if he gets a position, I would happily help him. You see, Ravi, I have been to small towns extensively in the process of teaching diagnostic or operative laparoscopy. And I'm amazed at the skill and the dedication of small town doctors. They, according to me, small town surgeons, according to me, are the backbone of Indian surgery. They do things which just as well in the terms of result as we would do with our sophistication. They might do it boiling the instruments on a kerosene stove, but the end result will be the same. And I have traveled extensively in India, and I have a lot of respect and friends amongst the rural surgeons. And I would be happy to go overboard to help anyone who has been a true rural doctor, because he is going to go back and do much more than the MS student I'm training at KM will do for society.
That is a very valuable piece of information, because young medical doctors just look down upon rural work.
That is the tragedy of it.
Yeah, it's unfortunate. I mean,
if they go there and see them work,
yeah.
I used to go ostensibly to teach, but I returned home humbled by seeing what they were doing.
Okay.
Humbled and educated.
Okay. The other practical question that I ask is this. You have a young resident and you let him do a laparoscopy. The trocar punctures the aorta. You do everything possible. This young resident who is doing his first laparoscopy loses the patient. What would you tell him?
I tell him that I lost the patient, not him. Because the buck stops with the chief. And if I let him do it when he was not ready to do it properly, or didn't supervise him properly, he didn't rupture the aorta, I ruptured the aorta.
Yeah, I mean, that sort of counseling and support, I'm sure will do a lot of, will be a great boost to young doctors who make mistakes. Everyone makes mistakes, and I suppose, yeah, everybody makes mistakes. The next thing I want to ask you about is a little, I wouldn't say tricky, but something that needs wisdom. If you have a situation where you have a colleague who makes a mistake in patient care and forges documents, and you know that he has forged a document to escape inquiry, what would you do?
If he was in my unit, that would never happen. If he was in other unit over which I had no jurisdiction, I'd tell him that this is something wrong that has been done, but I have no jurisdiction over his thing. If came to, in my days we had death conferences.
Yeah.
Every unit would present every death, and that was a very educative, and each unit would compete to say that this was not a error of diagnosis or error management. It was God only knows of patient disease. But if it came to open conference, I would say that what you've done is wrong.
Okay. I mean, we call these mortality morbidity conferences now, and unfortunately, the rigor of old death conference that when I have attended as a student in GS is no longer there. Those traditions are slowly dying for whatever reason.
They were the main piece of the whole month, where every registrar would present his debts and the chiefs would be there to pass judgment.
The next issue was about postmortems. The rate of postmortems at KEM is gradually falling, is steadily falling for complex reasons. How much learning? I'm asking a rhetorical question, but how much learning do you think happens from a valid postmortem?
You get to know the truth.
Okay. And then we have these issues now of coroner's permission and stuff like that. But even amongst the other side, the one that asks for postmortem, the interest in learning from postmortems is a little less than before. I won't say it's not there at all, but it is much less than what it was. Like, for example, Dr. Dastur's time or Dr. Sunil Pandya's time in neurosurgery, where every death was autopsy. The final question I have for you is a difficult question. And that's a question that has been bugging me. That has nothing to do with the interview that we have. And the question is, because you are 90 years old, because
I'm 88.
Okay. Plus minus 2 years is always a lot. When you're a medical doctor, you allow a lot of plus minus. Okay. Because 90 years is more wisdom than 88 years. I want to ask you this. What is wisdom?
That's a difficult question.
This is your exam question.
Wisdom is a collection of past experiences which are computerized in your brain and stored, and at a time of recall, you can get out the answers and use your past experience. Wisdom essentially is a lifetime collection of what you've learned. It is not got from outside. Wisdom, as they say, knowledge comes, wisdom lingers. And wisdom, I think, is intuitively built into people. As they appraise everything that's happened, all the mistakes they've made, all the failures they have had, the accumulation of all that integrated is, I think, what ultimate wisdom is. And when you appreciate your mistakes and understand and accept them, I think that is the fundamental importance of having true wisdom, where your ego is suppressed and the truth comes out.
I asked you this question with a very ulterior motive, because as you get older, I mean, wisdom in general is related to lived experiences, and that's more when you live longer. Given that wisdom is what it is, would you say that the deans, the municipal corporation should openly invite retired faculty, old people, back into the hospital as honorary faculty to teach or train or whatever, because they carry so much wisdom with them? Do you think that should be done?
Totally. I think, for that matter, I have recently written that all retired people should be because we have such a shortage of doctors. This country has about the greatest, with a high population and a low medical rate, we have the greatest shortage of doctors. And the best doctors are at 58, 68, retired out, when, according to me, they're at their peak. According to me, a doctor is at his peak from 55 to 70. A surgeon, at least. That's my assessment. Because he may not be manually as good, but his collected wisdom will make up for his manual deficiencies of what a 30-year-old boy would have. And I feel that we are wasting such a large amount of talent in this country. And that is why when I wrote an article on surgical care for all, I said we must get all our retired people on the field. We have such a shortage of doctors. And at the peak, these are being wasted. I think this is one of the stupidest things not to see the obvious, that we are throwing away our people at their peak.
Now that you have said this
Your
so
question
emphatically,
your question is a no-brainer. Of course, they must be brought in.
sometimes these have to be emphasized by people like you so that we have a case to build up to the powers that be to tell them, see, this is
Of
what
course,
great
I
teachers.
think we are throwing away our doctors at their peak. I cannot understand. And you see, if we had surplus doctors, that might be understandable. But we are not saying that you're going to take, not let the low guy come up again, but we are saying that you should be recycled. You know?
Yeah. Age no bar.
And this is, I've written this. I've written.
Okay.
It's not that I'm saying it for the first time. This is in writing.
Okay. I'm done. We have exceeded time. I'm done more or less with all the questions, but do you have anything to tell young GSIs, other doctors, the rest of the world?
I think we are so privileged in this country to be doctors. We have the privilege of a patient load which accepts us without prejudice, without question, especially in small town and rural India. The patient treats us well. Recent cases of abuse of power by patients is seen, but this is an aberration which should be stamped out. But I think we should be grateful to be where we are and thank God that we have the opportunity to do the work we should be doing and doing well.
Okay, thank you, sir, very much, because there are some very practical points in your talking, and I hope we can implement at least some of them.
Okay.
And as I end, I want to say something, and I'm serious, that I have not bought your book. I could almost have bought it from Amazon. I have not bought it because there is an unwritten rule that in an interview like this, the author gives an autobiography copy of the book to the person who troubled him during the interview.
How do I send it to you?
No. We'll work that out a little later. I'm only half joking, but that would be a privilege for me. I would work out how that can be done. And all of us, on behalf of all Bachchu Log, I call all students Bachchu Log. Small Bachchus undergraduate, big Bachchus postgraduate. Of all.
Daddy Cooper called us all Sonny.
Oh, okay.
Daddy Cooper, we called him Daddy.
Okay.
And everybody to him was Sonny.
Yeah, I use the word Bachchu Log very, very often. And on behalf of them, on faculty and all of us, and my own personal behalf, thank you for spending time with us. And there is so much to
For
learn.
GS Medical College, there is nothing I would not do. NKM.
Yeah.
Because that is where I grew, and that is where I am what I am.
And I will end on this note, like you offered. One day we will call you to a full house of the MLT and talk to us on anything that you want to talk about. Thank you, sir.
Not at all. Thank you. Nice talking to you, Ravi. All the best.
Thank you very much, sir.
God bless.
Yeah.
I would like to request, sir, to play the reflections video by Dr. Swarupa Bhagwat.
Dr. Sir, can I? Okay.
No, hello. In this one, it's not required. In this particular one, Varun can complete with the vote of thanks.
Okay. Yes, sir. Yes, sir. We thank Dean Dr. Sangeeta Rawat ma'am and Academic Dean Dr. Pathak for the continued support and encouragement. We also thank Dr. Ravi Ramakandan sir for giving us an introduction to Dr. Udwadia and the wonderful interview. We are truly grateful to Dr. Farooq and Dr. Udwadia for sharing their experiences and wisdom. We also thank the Gosumec Alumni Association for their contributions and their We also thank the Gosumec Alumni Association for administrative support for correspondence and financial transactions for Dr.M.V.L.Kothari, Chair and Division of Medical Humanities. We also thank Mr. Tushar and Mr. Badal for audio, visual, and technical support, Dr. Mehtre for video recordings. Last but not the least, a big thank you to the batch for the enthusiastic participation. Thank you.
Thank you.